Assalamu alaikum. I'd like to thank the GIS leadership for this great conference. And I think everyone in the first row, probably they need an Impella right now because they've been sitting since the morning. Dr. Haider really made my presentation super easy. I want to reiterate the 3 facts that he mentioned. Fact number 1, the outcomes of cardiogenic shock is dismal. The mortality is 40 to 50%. Balloon pumps do not work. If you've seen balloon pumps work, you've just seen the patient survive cardiogenic shock despite the balloon pump. So the balloon pump did not make the patient live. The patient lived, and they happened to have a balloon pump on board. This has been shown in randomized clinical trials. I don't think they should be on the shelf anymore. I don't think they should be implanted anymore. I think they should be withdrawn from the market. The third point is really we do need a systematic approach to cardiogenic shock. Dr. Haider went through this graph beautifully, but I think we should really unify our language and really recognize where is our patient, where does this patient fit on the spectrum. And I want to recognize that often we don't know when patients are sliding, how fast are they sliding? Are they going to stay in class B for 2 minutes, 2 hours, 2 days, or for how long? And that's extremely difficult to predict. If we manage to find predictors of who is going to slide and how fast, I think that's going to be the next big thing in cardiogenic shock rather than mechanical support. I'm going to start this with a case. So this is a 67-year-old man who was coming to Jeddah for Umrah from Europe. And he had severe dyspnea while on the airplane, had chest pain. The plane landed emergently in the northern parts of Saudi Arabia. He was rushed to the hospital there. He was predominantly short of breath, orthopnic, and had mild chest pain. On arrival, he had a heart rate of 97, a blood pressure of 119/72. He was tachypnic, and he was hypoxic. He required oxygen, and despite high dose oxygen, he was still sitting only 95%. He was taken to the cath lab, and an angiogram this is his ECG on initial presentation. Clearly an ischemic ECG, right bundle branch block, first degree AV block, rapid heart rate with diffuse ST segment depression, most pronounced in V2, V3. This is his angiogram report. So essentially, left main disease, severe proximal LAD disease. Circ was reported to be open and a C2-OD RCA. The disease was described as Medina 111 in the left main, so it was complex, and the angiographer at that place thought urgent bypass would be the best idea. So he was transferred to our hospital as a life-saving case. So right now he's off inotropes, so he's in that range, B, sliding into C. Upon arrival to our hospital, he was definitely worse than upon arriving to the other hospital, so he's no longer B, he's definitely in class C right now on arrival to our emergency room. He was not having chest pain, but sometimes if we really pressed him, he would say, yeah, I do feel something in my chest. But he was definitely tachypnic, clearly in heart failure. He was struggling to breathe. We moved him from face mask to non-invasive positive pressure ventilation with BiPAP. His lactate was 8, his pH was 7.14, and he was not on any inotropes. And he was more tachycardiac, and he was more tachypnic. So clearly sliding very fast from B to C and not doing very well. We had technical issues trying to open his angiogram, and after the initial stabilization with just inotropes, we managed to get his lactate 50% lower, so it dropped from 9 to almost 4.5. We fixed his acidosis with insulin, a single inotrope, and non-invasive positive pressure ventilation. The plan initially was, let's optimize him, support him medically, bridge him to bypass, to CABG in a few days. With difficulties, we managed to open his angiogram, and as we were reviewing his angiogram, unfortunately, he went into VT, arrested, required CPR for 10 minutes, and he was resuscitated, and after ROSC, he was on 2 inotropes, and we took him to the cath lab. Now, this is a gentleman who went from B to C to now D and going into E. In the cath lab, we started Impella initially up front prior to the angiogram, and then this is his angiogram. So you can see a short left main, a nub in the circ, so a totally occluded circ, severe, heavily calcified proximal and mid-LED disease. You're seeing the same thing. The contractility is clearly very, very poor, and you can see heavily complex disease in the LED. We wired both vessels. We ballooned the circ to reestablish flow, and the option of surgery was clearly out at this point. So we went ahead, we stented the circ, we stented the med-LED, and then we performed a DK crush to cover the osteal LED disease. We finished this with unacceptable results. So we measured his hemodynamics at the end, so after really the decision of putting the Impella up front. And he was clearly volume overloaded with an RA of 20 and with a PA pressure of 35 to 20, so really narrow pulsatility. And now I want to also bring your attention to how this patient slid from B to C to D in the matter of 12 hours. His cardiac output was measured using Fick equation at 3. Interestingly, the Impella reports a cardiac output of 3.5. A day later, he improved for 12 hours, then had PA arrest, and we discussed escalating his support, and then we decided that this is actually futile, and unfortunately, we discussed him in the ECMO team, and we elected not to escalate further. So I just want to bring this as physicians, sometimes we remember the cases that go well, but we also don't remember the cases that don't go well. So here, I think the Impella did not help. So in a randomized clinical trial, this patient would count as someone who went in, randomized to an Impella, and then had the event. Unfortunately, as physicians, sometimes we cannot remember that and we cannot recall that. And we only recall the cases like the great case that was presented earlier by Dr. Helmi, where an Impella went in and the patient had a left main thrombosis, and the operator opened both vessels, aspirated the left main, and the patient made it. Did that patient make it because of the Impella, or did that patient made it because of the left main revascularization? We need randomized clinical trials to inform this. Having an experience and saying that we put an Impella in and then the Impella helped the patient is just not enough, because we suffer from recall bias, and we really cannot judge this just based on case series or registries. If the Impella will do such a great job, and if the registries are correct, then the registries in the so-called shock programs report a mortality rate of 80%, or sorry, a mortality rate of an improvement of 30%. Well, that would be very clearly shown in RECOVER 4 or in any randomized clinical trial. That has not happened yet. So my point is, I think shock is extremely complex. Who's going to slide and how fast is very, very difficult to know. And once this concept of biochemical shock or irreversible cell injury occurs, no amount of mechanical cardiac support is going to help. Thank you.